Hello, good afternoon, third year. So here we are once again in the post-operative care. We'll continue our lecture regarding perioperative nursing. So we're now in the post-op care of our clients. So our goals here is to remain or restore homeostasis and prevent complications that may happen post-operatively, maintain adequate cardiovascular and tissue perfusion, most especially if there are a lot of blood that was lost during the operation. Maintain adequate respiratory function as well, because remember, the anesthesia has an effect on the respirations of the patient. Maintain adequate nutrition and elimination. Most especially, we need to improve the client's nutrition for proper wound healing of the incision site. Maintain fluid and electrolyte balance as well by administering the appropriate IV fluids of the patient. Maintain adequate renal function. So, together with the IV fluids, we need to check the renal function of the patient as well by checking the output, checking the urinary parameters, the lab values regarding the renal system. Promote adequate rest, comfort, and safety. So, after the patient has been operated on, they need a lot of rest and comfort. And we need to keep the side rails up just in case the patient is restless or what. Promote adequate wound healing. So, one of our responsibilities is to change the dressing of the patient from time to time and promote and maintain activity and mobility. So, as long as the patient is already able to sit up straight, we are going to promote activity and encourage early ambulation for the patient. And of course, provide adequate psychological support, most especially if the patient has lost a body part during the operation. Let's say, for example, they are amputated, they are going to suffer psychologically there because of the loss of limb. So now we go to the PACU care, or the post anesthesia care unit care. So transport of client from the OR to the RR, to the recovery room. So we are going to avoid exposure to an infection of the patient. Avoid rough handling as well, because the patient is not fully conscious after the operation, especially if the patient has undergone general anesthesia. And avoid hurried movement and rapid changes in the position. So if you're going to properly position the patient, do it gently, do it slowly. So one of our initial nursing assessment is to verify patient's identity, operative procedure, and the surgeon who has performed the procedure on the patient once they are already in the RR or the PACU. And we need to evaluate the following signs and verify their level of stability with the anesthesiologist, such as the respiratory status, circulatory status, pulses, temperature, the oxygen saturation level, and the hemodynamic values. That's why during the recovery phase of, or in the recovery room, we need to monitor the patient's vital signs post operatively in order to assess these things. Aside from the vital signs, we need to check their O2 saturation levels and check their blood values as well. We also need to determine the swallowing and gag reflex in order to check for their ability to take in food. That's the purpose of that. Level of consciousness and patient's response to stimuli is also very, very important. We need to evaluate lines, tubes, or drains to, and estimate blood loss as well, condition of the wound. So from time to time, when we are checking the dressing or changing the dressing of the incision site, we need to check the condition of the wound, medications that have been used, transfusions, and output. Evaluate the patient's level of comfort and safety as well. As long as the patient is already conscious, we need to ask this from the patient. If the patient is still in pain, The patient needs analgesics for the pain that they're feeling. We also need to perform safety checks. That's what I've told you earlier, to raise the side rails up. Restraints are properly in place as well. Evaluate the activity status of the patient and the movement of extremities. And review the healthcare provider's orders or the doctor's orders. We need to review them. Initial nursing interventions. We need to maintain a patent airway. So we allow the airway or the ED tube to remain in place until the patient begins to awaken and is trying to eject the airway. So if the patient is still unconscious, the ED tube that has been used for the general anesthesia should still be in place. Take note that will only be removed once the patient is already conscious. So the airway keeps the passages open and prevents the tongue from falling backward and obstructing the air passages. And if there are any secretions that you have heard, we need to aspirate excessive secretions when they are heard in the nasopharynx and the oropharynx. Assessing the status of the circulatory system. Take vital signs per protocol until the patient is well stabilized. So it depends on the hospital whether it be done every 15 minutes, every 30 minutes. So it really depends on the institution. Here in the local hospitals that we have here, once the patient is at the recovery room, we monitor the vital signs every 15 minutes. Together with the intake and output, we need to monitor that as well. And recognize any early symptoms of shock or hemorrhage, such as cool extremities, decreased urine output, which is less than 30 ml per hour, slow capillary refill, which is greater than 3 seconds or 2 seconds. There's a low BP, narrowing pulse pressure, increased heart rate. So if you see these signs, if you see hypotachy-tachy, what is hypotachy-tachy? Hypotension, tachycardia, tachypnea. If these are present, that means that the patient is having a hypovolemic shock. Probably hemorrhage is happening. Internal hemorrhage is happening to the patient. We need to check for those things. So if that is observed by us nurses, we need to initiate oxygen therapy in order to increase the oxygen availability from the blood and place the patient in shock position with his feet elevated unless it is contraindicated. So usually they are placed on Trendelenburg position to increase the oxygen in the brain of the patient via the force of gravity. Maintaining adequate respiratory function. So we need to place the patient in a lateral position with neck extended, if not contraindicated, and upper arm supported on a pillow. And turn the patient every 1 to 2 hours to facilitate breathing and ventilation. We are also going to teach the patient to take deep breaths and use an incentive spirometer. Assess lung fields as well, frequently by auscultation, and periodically evaluate the patient's orientation, response to name, and command is the one that we are going to do. And note that alterations in cerebral function may suggest impaired oxygen delivery. So they may need oxygen if they're somehow disoriented, they have slurred speech. We need to administer oxygen as per doctor's order. We need also to assess the thermoregulatory status of the patient. So we need to monitor the temperature per protocol to be alert for malignant hyperthermia or to detect hypothermia, which can be the complications of anesthesia, and report a temperature over 37.8 degrees Celsius or under 36.1 degrees Celsius. Monitor for post-anesthesia shivering because this can be common. 30 to 45 minutes after admission to the post-anesthesia care unit. If you see patients who are shivering, offer them a blanket in order to control their body temperature. So provide a therapeutic environment with proper temperature and humidity. So that's what we do. Once we see a patient in the PACU who is shivering, we somehow um, increase the temperature of the room since the room is air conditioned in order for them not to feel cold and offer them a blanket. Another would be maintaining adequate fluid volume. We need to administer IV solutions as ordered and monitor for evidence of fluid and electrolyte imbalance, such as nausea and vomiting. So, if that is present, evaluate mental status. Skin color and turgor should be noted as well. And recognize signs of hypovolemia. I've already mentioned that again earlier. Hypo, taki, hypotension, tachypnea, and tachycardia. Decrease urine output, decrease central venous pressure, and increase pulse rate. Hypervolemia if you are administering too much IV fluids. So there's an increase in BP, changes in lung sounds, and you can assess for the S3 gallop, blub, dub, dub, blub, dub, dub, blub, dub, dub, and increase central venous pressure. Again, monitor the intake and output of the patient for the fluid volume assessment. Minimizing complications of skin impairment. So, before and after, we are going to render care to our patient, most especially if we're going to use our hands on the patient, we need to perform hand washing before and after. Inspect the dressings routinely and reinforce them if necessary. So every now and then, that is our job to inspect the dressing and change them as needed. Record the amount and type of wound drainage as well, and turn patient frequently and maintain good body alignment, most especially if the patient will be at the hospital for a long time. Maintaining safety, keep the side rails up until the patient is fully awake. That's very, very important. And protect the extremity into which IV fluids are running so the needle will not become accidentally dislodged. So you need to check that every now and then, because if the needle has been dislodged, it's another problem that we are going to do at the PACU. We need to reinsert the IV. That's one of the most common problems at the ward or at certain units at the hospital. Dislodgement of the IV line. So it is an additional task, additional burden to reinsert their IV line again. So we should be very, very wary of the IV line of the patient because they can cause dislodgement of the IV needle. Avoid nerve damage and muscle strain by properly supporting and padding the pressure area, especially if the patient is going to stay at the hospital for a long time. Recognize that the patient may not be able to complain of injuries such as pricking of an open safety pin or clamp that is exerting pressure. So you need to check that as well because the anesthesia can cause these things or can numb the patient. So we need to check if there are any safety pins or any clamps on the patient's body. Check the dressing for constriction as well. So check if certain dressings can cause constriction of an extremity or the skin because it can further irritate the skin. Parameter for discharge from the PACU or recovery room is activity. If they are already able to obey commands, the patient will be removed or discharged from the recovery room. Respirations, it's easy and noiseless breathing. Circulation, BP within 20 millimeter mercury of pre-op level. Consciousness, they are already responsive. They're fully conscious, they're fully aware. Color, pinkish skin, and mucous membrane. So if these are already present on the patient, they can already be discharged or transferred from the PACU or recovery room to the surgical ward. Nursing care of the client during the intermediate post-op period. So this from the recovery room to the surgical unit. Baseline assessment again of the respiratory, cardiovascular status, vital signs, color and temperature again, skin, together with the level of consciousness. Check for the tubes, the drainage, the NGT, the T-tube, and proper positioning is important. Immediate post-op assessment and interventions. Areas of concern. First is neurological status. Our intervention is to assess the level of consciousness if they are responsive to their own name. We are also going to assess for the swallow and gag reflex. This is one of the common board exam questions. When are we allowed to feed the patient again post-op? Once the gag or the swallowing reflex is present. How do we elicit this? We elicit this by using the tongue depressor. So we depress the posterior portion of the tongue, and if the patient gags, that's the time the patient is allowed to be fed. Fluid and electrolyte balance. So again, INO is monitored together with the administration of IV fluids. For the dressing tubes and drains, check for the color, consistency, and the amount of drainage. For pain, may need 1/2 to 1/3 less analgesia in the recovery room. And safety and comfort, side rails should be raised. Warmth if they feel or if they experience chills or coldness. And aseptic technique is still used on these patients. Respiratory, again, assess. Always assess the respirations of the patient. Position on the side in order for them to easily breathe and keep airways patent. Administer oxygen as needed. Cardiovascular, again, assess for signs of hypovolemic shock. So assess for hypotachytachy, hypotension, cardiac arrest, or hemorrhage. So assess all those things. Aside from hypotachytachy, check for cold clammy skin, if they feel thirst, and if they appear pale. It means that they are suffering from hypovolemic shock. So this a summary of the patient care that we can do. It's a concept map of the patient care that we do post-op. Common post-op orders. They are NPO until fully alert. Okay? NPO until fully alert, or NPO until the gag reflex has returned. Then ice chips as tolerated. Advanced diet as tolerated as well. Suction as needed if you can see any secretions from, or if you can hear any secretions or crackles in the lung fields of the patient. Complete current IV, then discontinue is if the patient is already tolerating fluids. Compazine 5 milligram as needed for nausea and vomiting, because this can be one of the side effects of anesthesia. Morphine sulfate 10 milligram IM every 3 to 4 hours or as needed because of the pain felt in the incision site. Again, accurate intake and output should be monitored. Turn from side to side and deep breathing exercises every 2 hours. Hemoglobin and hematocrit is assessed in the morning. So it's the job of the medical technologist to gather or collect blood specimen from the patients. So it's usually in the morning. Catheter if patient can void within the next 8 to 10 hours. Maybe the anesthesia has an effect on the patient's bladder or the nerves that is supplying the patient's urinary bladder. So if they cannot void, we need to insert a catheter and reinforce dressing as needed. So every now and then we need to change that. So there, you just review this concept map regarding the post-op care or post-op recovery. So this is a monitoring sheet for the patient at the recovery room or PACU. Wound care. So commonly used wound dressing are these things, the gauze. And central line if CVP is going to be monitored from the patient. So the central line is going to be used to monitor the central venous pressure. Peripheral IVs are inserted as well. If the patient will be staying at the hospital for a long time, sacral pressure pads will be given to the patient to prevent sacral pressure ulcers. Skin protection dressings are important, most especially for the wound area. So the strips of tape should be placed at the ends of the dressing and must be sufficiently long and wide to secure the dressing. The tape should adhere to the intact skin. So the correct application of the gauze or the dressing together with the tape is in letter A. For letter B, as you can see there, it's too narrow and long. Don't apply the tape too long on the patient's dressing because the patient can come loose from it. Not also too short, not also too wide. It should be the one seen in letter A illustration. And when you are cleaning the wound, it's it can be cleaning from the top to bottom, starting from the center. So center first, and then the sides, eventually until the further sides of the incision. Or you can clean the wound outward from the incision. So you start at one side, one, two, three, four, and then the other side. So outward. Or if there is a Penrose drain, most especially if the patient has undergone GI surgery, you need to clean around the Penrose drain site. Okay? So it should be around, and you can clean it either clockwise or counterclockwise. It doesn't matter. But it should be starting from inner to outer portion of the incision site around the Penrose drain site. Wound irrigation. So in wound irrigation, one of our job is one of our job here, usually the ones who are doing this are the physicians, and we assist in the irrigation of the wound of the patient. So once the surgeon is going to do rounds and is going to do wound irrigation, we assist them in performing this for the patient. One of the things that we can teach the patient here regarding their incision site is in letter A, the nurse's hand should support the chest incision anteriorly and posteriorly, and the patient is instructed to take several deep breaths, inhale, and then cough forcibly. And then with one hand, the nurse exerts downward pressure on the soldier on the affected site while firmly supporting the area beneath the wound. With the other hand, the patient is instructed to take several deep breaths to inhale and then cough forcibly. After that, the nurse can wrap a towel or sheet around the patient's chest and hold the ends together, pulling slightly as the patient coughs and releases during deep breaths. And in order to guard their incision site, the patient can be taught to hold a pillow firmly against the incision while coughing. This can be also done while lying down or sitting in an upright position. So if the patient wants to cough, they can hold the pillow over that incision site to protect it because it can open up if the patient is coughing. So they need to protect their incision site by holding a pillow over it. So here are the different body positions or body pressure areas. So you need to take note of that. The heels, the sacrum, elbows, scapulae, and the back of the head are pressure sites in a supine position. In a sideline position, it can be the malleolus, knee, the greater trochanter, ilium, shoulder, ear, and the side of the head. For a prone position, the toes, knees, genitalia, breasts for females, shoulder, cheek, and ears would be the common pressure sites, while for an upright position or a high Fowler's position, the heels, pelvis, sacrum, and the vertebrae will be the pressure sites. So if the patient will be in a prolonged position for any of these positions, these are the things that we need to assess for any pressure ulcers, for the development of pressure ulcers. That's why it's important for us to turn the patient from side to side, put pressure pads over those pressure sites to prevent the formation of pressure ulcers. Now we go to post-op complications. So there's another concept map that we have here. You have urinary retention, pulmonary embolism, hypovolemic shock, infection, wound dehiscence, gastric dilatation, paralytic ileus due to the anesthesia, atelectasis or lung collapse, or even pneumonia. So you need to assess for any of these common post-op complications. If there's urinary retention, the patient is not able to void after 8 to 10 hours post-op. You can feel for the bladder, it's already full, and there's a frequent or small amount of voiding. There's a pain in the suprapubic area. If that happens, you need to insert a catheter. For the cardiovascular complications, hypovolemic shock, I've already mentioned to you the signs and symptoms of this. For pulmonary embolism, this can occur as well. Chest pain, dyspnea, tachycardia can occur together with increased anxiety, diaphoresis or excessive sweating, decreased orientation, decreased blood pressure, and decreased blood gas exchanges. So pulmonary embolism can occur post-op. And if that happens, a blood clot, an embolus of a blood clot can block the blood vessels that are supplying the lungs. And how is the lungs how is gas exchange going to occur if there is blockage? So that is also a dangerous complication post-op. Another would be wound infection. To assess if there's purulent drainage, if you see pus and there's redness, coupled with fever, tachycardia, and increased WBC or leukocytosis, those are signs of obvious infection. That's why sometimes to prevent infection to occur, doctors are going to prescribe antibiotics after the surgery is done. These antibiotics are helpful. They will be used as a prophylactic treatment to avoid the occurrence of post-op infection. Dehiscence, this can be common as well, wherein there is there is incision separation. So the wound site has opened in dehiscence and evidence of bowel through incision. Of course, there will be increased pain if there is wound dehiscence. So you can see that the incision site has opened. So the doctors need to close it up once again if that happens. So you need to check that for wound dehiscence, or even evisceration can occur, wherein the internal organs are coming out of the wound. Gastric dilatation can occur due to gas buildup. So the doctor will prescribe anti-flatulent drugs. And paralytic ileus due to the anesthesia, decreased bowel sounds, no stools or flatus, nausea, vomiting, abdominal distension, and abdominal tenderness is felt by the patient. That's why post-op, if the patient is already at the surgical unit, we need to ask the patient if the patient has already either voided or has already passed out stools, or if the patient has already farted, for example. Because if they haven't passed out stools or voided, then we need to treat either urinary retention or paralytic ileus. Atelectasis can occur or lung collapse. So signs and symptoms would be dyspnea, decreased breath sounds, asymmetrical chest movement, and tachycardia together with increased restlessness. Pneumonia, most especially if the patient is immobile for a long period of time. That is known as hypostatic pneumonia. So rapid respirations are felt together with shallow respirations. Fever can occur. Wet breath sounds, or you can hear crackles. Asymmetrical chest movement is also seen in this patient, wherein um, the chest hindi siya pantay pag humihinga siya, yung paggalaw ng chest. There is productive cough. Hypoxia is also felt by the patient. Tachycardia and of course increased WBCs due to infection. So these are questions. So that's it guys regarding um post-op care. So it's very important for us nurses to monitor for these complications during post-op. And if you see any of these complications, they need to, or we need to inform the doctor immediately for them to be treated. Okay, so if you have any questions about post-op care for our clients, you can ask me about them. And remember, the post-op care, I'm not going to discuss them one by one here because post-op care of the different forms of surgeries varies. So let's say, for example, the post-op care of patients who have undergone a brain surgery is different from the post-op care for patients who has undergone thoracic or even abdominal surgeries. So they can be different. So you will base them from the different diseases that has different types of surgeries as well. So you will just refer to those things because post-op care really is different for the different types of surgeries that has been done. Okay, so that's it, class. Thank you very much for attending today's class with regards to post-op nursing care. So that's it for perioperative nursing. And I hope you've learned a lot with regards to peri-op. And I hope you'll be looking forward to having your operating room duties or rotation once this whole COVID-19 pandemic blows over. Thank you very much and have a great weekend, everyone. Bye.